Assalamu alaikum. Hope you are all doing well. And last time we discussed the upper respiratory tract infections in children, and this time we will discuss the lower respiratory tract infections or pneumonias in children. So I am Muhammad Awais and one of the assistant professors in Akhtar Said Medical College in Pediatric Department. So little about the description of introduction. As we already know, the incidence of pneumonia is almost in every age group, but particularly it affects more in infancy and in old age, so means extremes of age, uh, also in the childhood. Pneumonia is actually one of the major causes of death in all over the world. So, along with the diarrheas, so especially in countries like Pakistan, where the resources are very much limited, this is a big problem. Uh, so it is caused by a variety of viruses and bacteria, as in upper respiratory tract infections. So, but in most of the cases, we are not able to identify the organism. Um, Viruses are the most common cause in younger children, while the bacteria are common in older children. But this is not a hard and fast rule. What are the pathogens or organisms causing pneumonia in children? So, if you stratify or we classify in different age groups, different pediatric age groups, so we'll see newborn the organisms are from the mother's genital tract, particularly GBS, Group B Streptococcus, but also gram-negative enterococci like E. coli. If we talk about infants and young children, so in those kids, the viruses like respiratory syncytial virus (RSV) are most common, but bacterial infections like Streptococcus pneumoniae, Haemophilus influenzae, and if we talk about atypical bacteria like Bordetella pertussis and Chlamydia trachomatis can also cause pneumonia in this age group, along with the Staph aureus. In children over 5 years of age, Mycoplasma pneumoniae, uh, Streptococcus pneumoniae, and Chlamydia pneumonia are the main causes. And in all the age groups, Mycobacterium tuberculosis should be considered. Clinical features. So, what are the clinical features, or first, we talk about the symptoms in the children presenting to you with the lower respiratory tract infection. So it usually starts with the non-specific symptoms of fever, cough, and lethargicness. But afterwards, as the child gets more sick, more ill, so the child would not be very much eager to feed. So the mother would say that the child is not taking orally well, or if the child is on the bottles, the mother will say the child is not taking enough bottles, or if the child is on the breastfeed, the mother would say that the baby is not taking breastfeed well. So there would be significant change in form of the activity of the child, and the mother recognizes it well most of the time. And along with there would be difficulty in breathing, and in older kids they may complain of localized chest or abdominal pain sometimes. And specifically, if we talk about examination findings, that there would be tachypnea, means increased respiratory rate, and along with the nasal flaring, and uh, chest and drawing like subcostal, intercostal recessions. And if you auscultate the chest, you may find some coarse crackles over the affected area. Um, if you are able to do the dull percussion in the kids which are a difficult task, there may be the dullness over the area, affected area, and decreased breath sounds with the help of the stethoscope, and also there will be a bronchial type of breathing, which is abnormal in the chest, especially if you talk about. And if you take the oxygen saturation reading, that would be decreased, and that means like the child is not getting enough oxygen from his lungs, uh, and clinically the child may get cyanosed or off color. So these are two most common occurring pneumonias. One is bronchopneumonia, one is lobar pneumonia in the kids. And lobar pneumonia, as by name, it involves the whole lobe of the lung. And bronchopneumonia, in which there is usually a scattered appearance of the lesions, or scattered appearance of on the radiographs. So this is the one patch of consolidation, and these are a little bit scattered areas of consolidations. So if we compare lobar pneumonia with bronchopneumonia and interstitial pneumonia, the primary location of infection, if we talk about lobar pneumonia, it is in the alveoli, and in bronchopneumonia, it is in the airways like bronchi, and in interstitial pneumonia, it is within the interstitium of the lungs. If we look at the X-rays of different kinds of pneumonia, there would be dense consolidation patch, as we already have seen in the last photograph. One lobe would be involved, and in which we can see the air bronchograms on the chest X-ray, especially. So these would be the consolidated airways. And in bronchopneumonia, the same thing will be there, but in the form of patchy opacities in chest X-ray. And in interstitial pneumonia, there will be diffuse hazy opacities and septal thickening. We talk about ultrasound pattern. The consolidation would be of an extensive, and sometimes we may be able to find some kind of effusion, parapneumonic effusion on the ultrasound as well. And in bronchopneumonia, on ultrasound there will be patchy B lines and may have some consolidation. So if we go for the microbiology, in most of the cases of lobar pneumonia, the cause is Streptococcus pneumoniae, but other organisms can also give lobar appearance of the lungs on the X-ray, like Klebsiella and Legionella. In bronchopneumonia, the causative organisms most likely would be a wide variety of atypical organisms like Mycoplasma, Chlamydia, Pseudomonas, and sometimes Staph aureus. Interstitial pneumonia are due to some viruses and PJPs like pneumocystic gibboside pneumonia and Mycoplasma. If we go for investigation, chest X-ray may confirm the diagnosis, but with the exception of the classical lobar pneumonia, which is the characteristic of Streptococcus pneumoniae, chest X-ray cannot differentiate between bacterial and viral pneumonia. So even if it is lobar pneumonia, there is likely possibility of Streptococcus, but we can't say 100% that it is Streptococcus pneumoniae, because we need to confirm it on the blood cultures. So this is the classical presentation of lobar pneumonia. This is the chest X-ray of a child, and this is the cardiac shadow, and these are the lung fields. If you see this side, left side is okay relatively, and the right side, if you see, there is a white opacity on the upper zone of the chest X-ray, and this is involving the whole upper lobe of the right side of the chest, right side of the lung. And if we see closely, there along with the homogeneous opacities, there is some air bronchograms, these black areas, and this border of the heart is obscured. It is called Sillett sign. So these are all the radiological findings in the consolidation or pneumonia. In younger children, a nasopharyngeal aspirate is useful to identify viral cause, like in respiratory syncytial virus and bronchiolitis. Sometimes we offer nasopharyngeal aspirate, and when we do the examination, sometimes we would be able to identify respiratory syncytial virus. But like blood tests and including full blood count and acute phase reactants like CRP are generally unhelpful in differentiating between viral and bacterial cause. And blood culture is useful, but unfortunately it is not present in all of the cases of the affected patients. Like if 100 patients are actually affected with the pneumococcus, we may have some 34-40% blood culture positive in that kids only, but the disease would be in rest of 70 to 40% as well. So blood culture definitely confirms, but if the blood culture is negative, that doesn't mean that the infection or the bacterial infection is not there. Complications, what could be the complications of pneumonia? Small proportion of pneumonias are associated with a pleural effusion, where there may be blunting of the costophrenic angle of the chest X-ray. Costophrenic angle is the angle between the ribs and the diaphragm. Some of these effusions develop into the empyema. So empyema that may get secondarily infected the effusion. So that may be you can say the pus inside that area, and fibrin strands may form, leading to septations which make drainage difficult. Ultrasound of the chest will often distinguish between parapneumonic effusion and empyema. So this is the chest X-ray showing lobar pneumonia most likely, and this is the costophrenic angle, which is obliterated, although the cardiophrenic angle in this is also obliterated. So this is the effusion inside the right side of the lower chest. How we will manage the cases of pneumonias in children? Most cases can be managed at home, like if they don't need oxygen or they are not very severe. But indication for admission include oxygen saturation less than 93%. If you take the saturation of the child, the saturation would be less than 93%, and the child would be cyanosed. These are the candidates for the admissions. If there is the kidney is out of proportion, and if there is difficult breathing, along with if the child is early infant, there would be some funny sound like grunting sounds due to air compromise, or if the child is a newborn baby or early infant, there may be pauses in the breathing, and that are called apnea, along with the bradycardia. Not feeding, or the child is not feeding well, or the family is uneducated, and definitely, and they are coming from far areas, you need to keep the baby inside the hospital at least for that particular night. Management, there are general supportive care include oxygen for hypoxia and analgesia if there is any pain or fever. We should maintain the hydration, or if not the child is not taking orally, then we need to give nasogastric feeding, and if the child is not able to take nasogastric, then we need to give IV fluids, and physiotherapy has got no role. The choice of antibiotics is determined by the child's age, severity of illness, and appearance on the chest X-ray. Definitely after blood culture, it depends upon the organism of the causative organism as well. So newborns, we need broad spectrum IV antibiotics like combination antibiotic, cefotaxime, Bracil, cefotaxime and amikacin, and most older infants can be managed with oral amoxicillin, and the areas where there are resistance to amoxicillin, we can use moxiclav or ceftriaxone. And for children more than 5 years of age, either amoxicillin or an oral microlide such as erythromycin or clarithromycin. If the child is allergic to penicillin, we can also give clarithromycin or erythromycin. Management of parapneumonic effusions are usually resolved with the appropriate antibiotics, but the small proportion that develop into empyema, they require drainage of the collection. This may be achieved by either placement of chest drained with or without the installation of fibrinolytic agent in the intradural space, for example urokinase, to break any septation or by surgical decortication. But in simple case, we only put the chest drain with the underwater seal. Practices may vary between different centers of the same countries as well. So prognosis is generally good. Follow-up is not generally required for children with simple consolidation on chest X-ray and who recover clinically. Those with evidence of lobar collapse, atelectasis, or empyema should be having a repeat X-ray after 4 to 6 weeks. And virtually all children with pneumonia, even those with empyema, make a full recovery. What is the prevention? First, prevention is definitely hygiene, nutrition, and then vaccinations are available. A conjugate vaccine Prevnar with immunogenicity against 13 of the most common types, serotypes of Streptococcus pneumonia, responsible for invasive disease, and is now included in the routine immunization schedule in the UK and in many countries. In Pakistan, there is also a conjugate vaccine against pneumococcus we give in EPI schedule. By EPI, I mean extended program of immunization of Pakistan. There has been a marked reduction in the incidence of pneumonia from Haemophilus influenzae type B since the introduction of Hib immunization. That is also the part of our vaccination schedule in Pakistan. Thank you very much. And if you have any questions, you may comment underneath the YouTube channel, or you can talk to me through Facebook as well. Thanks very much. Thank you.